Welcome. Today we're doing a fast, um, really high-stakes analysis of critical care respiratory emergencies.
Yeah, this is the stuff that demands immediate focus.
Exactly. We're pulling directly from our source material, focusing on those acute, life-threatening situations where gas exchange and perfusion just plummet.
That's right. And when these systems fail rapidly, you really only have minutes to intervene effectively.
So for critical care respiratory medicine, what's the absolute core concept we need to anchor ourselves to?
It's gas exchange. Always. When we analyze a patient who's crashing, what we're really looking at is a fundamental failure in how the body's exchanging oxygen and carbon dioxide.
Okay, gas exchange. But that doesn't happen in isolation, does it?
Not at all. You absolutely have to consider the interrelated concepts. Perfusion, that's the blood flow needed to actually transport the oxygen, and clotting. Clotting is often the mechanism that just, well, shuts down that vital blood flow.
Got it. Gas exchange, perfusion, clotting. And you mentioned there's a key exemplar for today.
Yes. Our primary example for understanding this whole cascade failure is the pulmonary embolism, or PE. We're going to synthesize the pathophysiology, the signs which can be subtle, the high-stakes diagnostics, and, critically, the nursing actions that have to happen like that.
Okay, let's dive straight into PE then. How does it cause such chaos? What is a pulmonary embolism fundamentally?
A pulmonary embolism is essentially when some kind of particulate matter, could be solid, liquid, even air, travels through the bloodstream and gets lodged in the pulmonary vessels.
And usually it's a blood clot.
Most commonly, yes. A thrombus, typically one that's broken off from a deep vein thrombosis, a DVT, often in the legs, it travels up and bam.
So think of it like a plumbing clog, but in the lungs.
Exactly. It's a massive clog in the lungs' circulatory system. And the immediate effect is that you have air coming into the alveoli. Ventilation is fine initially, but you've got zero blood flow getting past that clot. Perfusion is blocked.
Ah, the VQ mismatch.
That's the one, the notorious alveolar perfusion mismatch, or VQ mismatch. Big problem.
And the consequences stack up fast, I imagine.
Terrifyingly fast. Those non-perfused areas, they just can't oxygenate blood. So you get reduced oxygenation system-wide, tissue hypoxia starts setting in, and perfusion drops because the heart is straining against that blockage in the pulmonary artery.
And in severe cases.
In severe cases, the patient develops refractory hypoxemia. That means their oxygen levels are dangerously low, and crucially, they don't improve much, sometimes not at all. Even if you put them on 100% oxygen, it's a really bad sign.
Okay, so knowing who's at risk is key for prevention. The sources list things like prolonged immobility, major surgery, pregnancy, central lines. Is there a common thread there?
Absolutely. If you look closely at that list, you'll see they almost all relate back to one or more parts of Virchow's triad. Remember that.
Damage to the vessel wall, stasis or slow blood flow, and hypercoagulability.
Exactly. Stasis from immobility, vessel damage from surgery or lines, hypercoagulability from pregnancy or certain conditions. That triad is really the foundation for understanding VTE risk and prevention.
We shouldn't forget lifestyle risks either, like smoking.
Definitely not. Smoking constricts blood vessels, makes blood clot more easily, and combining smoking with things like hormone-based contraceptives, that significantly bumps up the risk.
Let's talk presentation. What are the key features we absolutely need to recognize instantly?
There's sort of a classic picture, though not every patient reads the textbook. You look for a sudden onset of dyspnea, shortness of breath hitting out of nowhere.
Okay, sudden dyspnea. What else?
Then there's often a sharp, stabbing chest pain, usually pleuritic, meaning it gets worse when they breathe in.
Sharp pain, worse on inspiration. Got it.
And this one's crucial, a feeling of intense apprehension or impending doom. Patients might literally say they feel like they're going to die.
That impending doom phrase always sounds dramatic, but you're saying take it very seriously.
Absolutely. In critical care, that subjective feeling is a powerful indicator. It often precedes hemodynamic collapse, which leads to a huge nursing safety priority. If you have an at-risk patient suddenly develop shortness of breath, chest pain, or maybe their blood pressure just drops for no clear reason,
You hit the panic button.
you initiate the rapid response team immediately. Don't wait for labs, don't hesitate. Get help to the bedside now.
Okay, immediate action. But eventually we do get labs. What do the ABGs show?
Initially, because of the pain and distress, they're often hyperventilating, breathing really fast. So the first ABG might actually show respiratory alkalosis. They're blowing off too much CO2.
Alkalosis first.
Yeah.
But that doesn't last.
No. As they tire out and the hypoxia gets worse, the picture shifts. The ABGs will inevitably trend towards respiratory acidosis from retaining CO2 and metabolic acidosis because the tissues aren't getting oxygen and start producing lactic acid.
And the key lab test to help rule out a PE.
That would be the D-dimer. It measures fibrin degradation products, basically evidence of clot breakdown. If it's normal or low in someone with low clinical suspicion, it makes PE less likely.
But it doesn't confirm it. For confirmation.
For definitive imaging, the gold standard is usually the CTPA computed tomography pulmonary angiography. It gives a direct view of the pulmonary arteries. And don't forget to consider genetics, inherited clotting disorders like factor V Leiden are important risk factors.
So PE suspected, RRT called. What are the first few stabilization steps? Oxygen, obviously.
Oxygen first, absolutely. Get the SATs up,
Okay.
then get the patient into high Fowler position.
Why high Fowlers specifically?
It does a couple of things. It helps maximize lung expansion, making breathing a bit easier. It also helps match ventilation and perfusion better than lying flat. And it can slightly reduce the preload, the amount of blood returning to the right side of the heart, which is already under strain.
Okay, oxygen, high Fowlers. Then what?
Secure 5E access immediately, you'll need it. Start continuous monitoring, pulse ox, cardiac monitor, frequent vitals, at least every 30 minutes initially, and then drug therapy.
What drugs are we talking about?
Primarily anticoagulants, usually IV heparin to start, or maybe low molecular weight heparin like enoxaparin. The key here is these prevent new clots from forming or existing ones from getting bigger. They don't actually dissolve the clot that's already there.
So what does dissolve the clot?
For that, you need fibrinolytics, like alteplase. But these are high alert drugs, big bleeding risk, so they're typically reserved only for massive PE where the patient is hemodynamically unstable, profound shock.
And briefly, are there surgical options?
Yes, though less common. An embolectomy, physically removing the clot, might be done for massive PE if fibrinolytics are contraindicated or fail. Or for recurrent PEs or patients who can't take anticoagulants, an inferior vena cava IVC filter might be placed to catch clots before they reach the lungs.
Makes sense. And before we leave PE, prevention is huge. Remind us of those key nursing actions.
Right, prevention is everything. Ambulate patients as early and often as possible after surgery. Use sequential compression devices, SCDs, or pneumatic compression devices. Critically, avoid putting pillows or pressure directly under the knees, the popliteal space that can impede venous return.
Keep the legs elevated.
Elevate affected limbs when possible. And absolutely, never massage leg muscles, especially if a DVT is suspected. You could dislodge a clot.
Okay, so PE is a major perfusion problem. Let's shift gears now to when the actual mechanics of breathing or gas exchange itself fails. That brings us to acute respiratory failure, or ARF. How do we define that? What are the numbers?
ARF is defined by specific arterial blood gas values. It's generally considered present if the PO2, the partial pressure of oxygen in arterial blood, drops below 60 millimeter Hg.
Okay, PO2 less than 60.
Or if the PO2 partial pressure of carbon dioxide rises above 45 millimeter Hg and there's accompanying acidemia, meaning the pH is less than 7.35.
And what about oxygen saturation?
And typically, the SO2, the oxygen saturation measured by pulse oximetry, will be less than 90%. The key takeaway is the patient is always hypoxemic in ARF. Low oxygen is the constant.
And the sources differentiate between two main types of ARF?
That's right. It's helpful to think about why the failure is happening. First, you have ventilatory failure. Here, perfusion, the blood flow, might be okay, but the problem is moving air in and out. Think inadequate ventilation.
So the pump isn't working.
Kind of. The patient can't maintain adequate minute ventilation, so CO2 builds up. That's the hallmark hypercapnia, or CO2 retention. It's an oxygen intake problem, fundamentally.
Yeah, the second type?
The second type is oxygenation failure, also called gas exchange failure. In this case, ventilation, moving air in and out might be fine, but the lungs can't get the oxygen from the alveoli into the blood effectively.
So the air gets there, but it can't cross over.
Exactly. The problem is with diffusion across the alveolar capillary membrane, or maybe perfusion is severely mismatched like we saw in PE. But this type often involves lung tissue diseases like pneumonia, pulmonary edema, or the big one we need to discuss, ARDS.
Right. Let's focus now on acute respiratory distress syndrome, or ARDS. This sounds like the most severe form of oxygenation failure.
It absolutely is. And the absolute hallmark sign you need to remember for ARDS is that refractory hypoxemia we mentioned earlier. Oxygen levels stay dangerously low despite giving high concentrations of oxygen.
Refractory hypoxemia. What else characterizes ARDS?
You also see decreased pulmonary compliance. The lungs become incredibly stiff, hard to ventilate. Think trying to inflate a brick. And on chest x-ray, you see non-cardiac bilateral pulmonary edema fluid in the lungs, not caused by heart failure, which classically shows up as diffuse, hazy infiltrates, often called a ground glass appearance.
Stiff lungs, fluid everywhere, terrible oxygenation. What's happening at the cellular level to cause all this damage?
It's essentially a massive, uncontrolled inflammatory response in the lungs, often triggered by sepsis, trauma, pneumonia, aspiration. Something sets off this systemic inflammation, sometimes called a cytokine storm.
A cytokine storm.
Yeah. These inflammatory mediators damage the delicate alveolar capillary membrane, making it leaky. Fluid and protein flood into the alveoli. This influx damages the type 2 pneumocytes, the cells that produce surfactant.
And surfactant is crucial for keeping alveoli open.
Exactly. Surfactant reduces surface tension.
Uh-huh.
Without enough surfactant, the alveoli collapse at the end of expiration. This widespread alveolar collapse is called atelectasis. So you have fluid-filled, collapsed alveoli across large portions of the lung. It's a functional disaster zone.
Wow. Okay. Inflammation, leaky membrane, surfactant loss, alveolar collapse. Managing this must be incredibly challenging. What's the cornerstone intervention?
Given that profound collapse and stiffness, the primary intervention is mechanical ventilation. But not just any ventilation. We have to use lung protective strategies. Meaning using low tidal volumes, typically around 6 millimils per kilogram of ideal body weight. This seems counterintuitive when the patient needs oxygen, but higher volumes can overstretch and further injure the already damaged lung tissue that's ventilator-induced lung injury, or VILISI. We want to avoid that at all costs.
Low volumes.
Yeah.
And what else is key on the ventilator?
Keep positive end expiratory pressure. This is critical. By maintaining positive pressure in the airways even during exhalation, PEEP helps prevent those damaged alveoli from collapsing completely. It basically props them open, improving oxygenation and reducing shunt.
And there's an evidence-based practice related to positioning.
Yes, a really important one. Prone positioning. Placing the patient face down on their stomach.
That sounds uncomfortable and difficult to manage. Why do it?
It seems counterintuitive, I know, but the evidence is strong, especially for moderate to severe ARDS. Proning helps redistribute blood flow away from the collapse-dependent lung regions towards better aerated areas. It can improve VQ matching, recruit collapsed alveoli in the posterior parts of the lungs, reduce shunt, and actually helps minimize VLA. It's become standard of care.
All right, let's switch from complex disease like ARDS to more direct mechanical injuries. Chest trauma. The sources emphasize that most chest injuries are actually managed non-surgically, but the starting point is always the same.
Always ABC. Airway, breathing, circulation. You secure those first, rapidly assess the extent of injury.
Okay, let's talk about a specific dramatic-looking injury. Flail chest. What is that exactly?
Flail chest occurs when you have multiple rib fractures specifically, 3 or more adjacent ribs fractured in 2 or more places each. This creates a segment of the chest wall that's no longer connected to the rest of the rib cage. It's unstable.
And that instability causes a very specific sign.
Yes, the defining feature, the thing you'll see immediately, is paradoxical chest wall movement. When the patient inhales, the negative pressure pulls that unstable segment inward while the rest of the chest expands. When they exhale, it balloons outward. It's the opposite of normal chest movement.
That looks painful and inefficient.
It is very painful, and it severely impairs ventilation. Management focuses heavily on pain control, often epidurals or nerve blocks to allow for adequate breathing and coughing. And they need oxygen, pulmonary hygiene.
Do they always need a ventilator?
Not always, but often. If the paradoxical motion is severe, or if they develop significant hypoxemia or respiratory failure due to the underlying lung contusion, they'll likely need intubation and mechanical ventilation with PEEP. The PEEP helps internally splint that flail segment.
Okay. Besides broken ribs, trauma can breach the pleural space. Let's cover pneumothorax and hemothorax.
Right. Simply put, pneumothorax is air in the pleural space, the space between the lung and the chest wall. This air causes the lung to collapse, partially or fully. Hemothorax is blood in that same pleural space, usually from injured blood vessels. Both impair breathing.
But there's one type of pneumothorax that's an absolute emergency, right?
Yes. The one you cannot miss, the immediate life threat. Tension pneumothorax.
Define that. What makes it a tension pneumo?
A tension pneumothorax happens when there's sort of one-way valve situation. Air gets into the pleural space with each breath, usually through a lung or chest wall injury, but it can't get out.
So pressure just builds and builds.
Relentlessly, the pressure builds up in the affected side, completely collapsing the lung. But worse, it starts pushing the entire mediastinum of the heart, trachea, great vessels over to the opposite side. This is called a mediastinal shift.
And that shift causes catastrophic problems. What are the signs?
The signs are extreme and develop rapidly. Severe respiratory distress, obviously, marks cyanosis. The trachea will actually be visibly deviated away from the injured side. You'll see distended neck veins because the pressure is kinking the vena cava, blocking blood return to the heart. Hypotension and shock follow quickly.
Tracheal deviation is the killer sign to look for.
It's a late but critical sign. If you see that or suspect tension pneumo based on the other signs, you have seconds, maybe minutes.
What's the immediate life-saving intervention?
Immediate needle decompression, also called needle thoracostomy. You insert a large bore needle into the second intercostal space, mid-clavicular line on the affected side. You should hear a rush of air. That relieves the pressure instantly.
And that's followed by?
That's just a temporizing measure. It needs to be followed immediately by placing a formal chest tube to continuously drain the air and allow the lung to reinflate properly.
Okay, whether it's from PE, ARDS, severe trauma, or something else, sometimes the lungs just fail to the point where the patient needs mechanical ventilation. Let's finish by talking about managing that patient on the vent. It's life support, but temporary, right?
Ideally, yes. Mechanical ventilation takes over the work of breathing, improves gas exchange, and allows the underlying problem to be treated and hopefully resolved. It buys time.
And it requires an artificial airway.
Correct. Usually an endotracheal E-tube is placed through the mouth or nose into the trachea. Once that tube is in, nursing safety becomes absolutely paramount. There are several critical checks.
What's the very first priority after intubation?
Verifying tube placement. Immediately. You check for end-tidal CO2 detection that confirms the tube is in the airway, not the esophagus. Then, auscultate for bilateral breath sounds. And critically, get a chest x-ray to confirm the depth, ensuring the tip is a few centimeters above the carina.
Okay, placement verified. What about the cuff?
The cuff on the ET tube needs to be inflated, but not overinflated. You need to maintain the pressure typically between 20 to 30 centimeters of water, centimeter H2O. Too low, and they risk aspiration. Too high, and you risk damaging the trachea. Regular cuff pressure monitoring is essential.
Got it. Now, let's say the patient's on the vent, and suddenly their oxygen saturation drops or the alarms are going off. What's the mnemonic nurses use?
The go-to mnemonic is DOPE. It helps you troubleshoot potential causes quickly.
E.
D stands for displaced tube. Has the tube move out of position, maybe into the right main stem or even out of the trachea.
Oh.
O is for obstructed tube. Is it kinked? Is there a thick mucus plug blocking it?
P.
P is for pneumothorax. Could the patient have developed a pneumothorax, perhaps from the ventilator pressure itself?
And E.
E is for equipment failure. Is the ventilator malfunctioning? Is there a leak in the circuit?
Okay, DOPE, displaced, obstructed, pneumothorax equipment. But there's a critical rescue step if the patient is in severe distress, even before running through DOPE.
Absolutely. This is crucial. If your ventilated patient acutely decompensates severe distress, plummeting SATs, your very first action should be to disconnect them from the ventilator and start manually ventilating them with a bag valve mask BVM device connected to 100% oxygen.
Why do that first?
Because it immediately rules out ventilator or equipment failure as the primary cause.
Yeah.
If they improve with bagging, the problem is likely the machine or circuit. If they don't improve, you know the problem is with the patient, likely a displaced tube, obstruction, or pneumothorax, and you proceed rapidly down the DOPE checklist while bagging. It's the fastest way to ensure oxygenation during a crisis.
Okay, critical step.
Yeah.
Now let's quickly review the main ventilator settings nurses monitor and manage.
Sure. You're constantly monitoring the tidal volume, VT, that's the volume of air delivered with each breath. As we said, usually kept low in ARDS, around 6 to 8 milliliters of ideal body weight for lung protection.
At the rate.
The rate, the number of breaths per minute set on the ventilator, usually somewhere between 10 and 14, but adjusted based on CO2 levels. FiO2, the fraction of inspired oxygen. This is the percentage of oxygen being delivered, anywhere from 21% room air up to 100%. We aim for the lowest FiO2 possible to maintain adequate oxygenation, usually targeting SO2 90% or PO2 60 mmHg to avoid oxygen toxicity.
And finally, PEEP.
And PEEP, positive end expiratory pressure. That vital setting we discussed for ARDS used to keep alveoli open, improve oxygenation, and prevent atelectasis. Usually started at around 5 centimeter H2O and titrated up as needed.
Ventilation is life-saving, but it carries risks. Yeah. What are the major complications, these ventilator-associated events, VAEs?
There are several. Cardiac problems can occur, like hypotension, because the positive pressure inside the chest can reduce venous return to the heart.
And lung problems.
Yes, significant lung problems. Barotrauma is injury from too much pressure, which can cause things like pneumothorax. Foley trauma is injury from too much volume stretching the alveoli. That's why low tidal volumes are key.
And the big infection risk.
The really big one is ventilator-associated pneumonia, VAP. Bacteria can get down into the lungs around the ET tube cuff or through aspiration of contaminated secretions. It's a major complication we work hard to prevent.
Which brings us to the ventilator bundle.
Mm-hmm.
This is a set of evidence-based practices, right?
Exactly. It's a core set of nursing interventions proven to reduce VAP rates significantly. It's non-negotiable bedside care for any ventilated patient.
Well, it's in the bundle.
Key elements include keeping the head of the bed elevated to at least 30 degrees, preferably 45 degrees, unless contraindicated. This helps prevent aspiration.
Oral care.
Meticulous, regular oral care is crucial. Usually involves using a suction toothbrush, chlorhexidine rinses, often done every 12 hours or even more frequently based on protocol. Gets rid of bacteria in the mouth.
Anything else?
Yes. Stress ulcer prophylaxis, medications to prevent stomach ulcers, and DVT prophylaxis are usually included. Plus, maintaining pulmonary hygiene, turning the patient, maybe chest physiotherapy if ordered.
And mobility.
Yeah.
I recall the source mentioning a shift here.
Yes. Early progressive mobility is increasingly recognized as vital. Getting patients moving, even while ventilated sitting up, dangling legs, maybe even chair or ambulation with ART support, has been shown to decrease ventilator days, reduce ICU length of stay, and improve long-term outcomes. It requires a real shift in the traditional ICU mindset of keeping ventilated patients strictly in bed.
Okay, so we're preventing complications. Eventually, the goal is to get them off the ventilator. This is weaning. How's that done?
Weaning is the gradual transition back to spontaneous breathing. There are different methods. Sometimes it's a gradual decrease in the ventilator's mandatory breath rate, using a mode like SAPE-V, synchronized intermittent mandatory ventilation, or using a T-piece trial where they breathe entirely on their own through the ET tube with humidified oxygen for a period.
Any other methods?
Pressure support ventilation, PSV, is common too. The patient triggers all breaths, and the ventilator just provides some pressure support to make breathing easier. Readiness for weaning is assessed daily based on clinical stability and oxygenation parameters.
And finally, the tube comes out. Extubation. What's the key concern right after?
After the ET tube is removed, you monitor them incredibly closely, especially their breathing pattern, work of breathing, vital signs, and oxygen saturation. The immediate post-extubation period is high risk.
And the one critical late sign of trouble we need to watch for.
The big one to listen for is stridor. That's a high-pitched crowing sound usually heard on inspiration. It indicates significant upper airway edema or obstruction, possibly from swelling after the tube is out.
Stridor is an emergency.
Stridor is an airway emergency. If you hear stridor, it means the airway is rapidly narrowing. You need to call the rapid response team or code team immediately. They may need reintubation urgently. #tag outro.
Wow. That was an incredibly dense but vital deep dive into critical care respiratory emergencies. We've really hit the high points, the absolute centrality of gas exchange, the real urgency needed for managing PE, recognizing things like Virchow's triad and those key symptoms like impending doom.
Yeah, and understanding the complexities of ARDS, refractory hypoxemia, stiff lungs, and how crucial those protective ventilation strategies like low tidal volumes and PEEP and even proning really are.
And threading through it all, the absolutely vital hands-on role of the nurse, assessing, intervening immediately for things like tension pneumo, managing the ventilator safely using DOPE and the critical rescue step, and meticulously applying that ventilator bundle to prevent VAP.
It's a huge responsibility. And that actually leads to a final thought, something pulled from the source material to consider.
Okay.
Well, the text notes that older patients often have a harder time weaning from ventilation. They have age-related changes like stiffer chest walls, weaker respiratory muscles. So ventilator dependence can become a real issue. It makes you think. Given this reality, how does the healthcare system need to adapt? How do we ensure we're making personalized, ethical decisions about long-term care and goals of care, especially when maybe the patient's wishes aren't clearly documented in an advance directive?
That's a heavy question. Dealing with potentially prolonged ventilation and difficult weaning decisions, especially without clear guidance, it's a massive ethical and practical challenge for families and ICU teams everywhere. Definitely something to mull over.
It is.
Well, thank you for guiding us through that intense material. And thank you, our listeners, for joining us on this essential deep dive from the Last Minute Lecture team. We hope this helps clarify these critical concepts. We'll catch you next time.